Screen visible?
Yes, sir.
Okay. So this is how I have prepared the answer for this. So medical nutrition therapy is an essential part of care of the critically ill patients. But optimal feeding strategy for patients in intensive care is still debated and often remains a challenge for clinical practice. The important questions you should ask before you think of nutrition is why nutrition is needed, who are all the patients who need this nutrition, when do you start this nutrition, how do you give the nutrition and with what. So these are the 5 questions that you should answer before you think of nutrition. Why nutrition? Who are the patients who need nutrition? When do you start the nutritional support? How do you give it? And what are all the preparations that you use? So if you answer these 5 questions, you will be able to answer your practical employment of nutrition in ICU as well as your answer paper. Why nutrition? The nutritional status is avoiding malnutrition in a primarily well-nourished patient. You must have seen some patients who are well-built. They remain in ICU on ventilator for a month or so. By the time they go home after weaning and all that, they would have lost at least 10 to 15 kgs. You can't recognize them from what their admission status was. So to prevent primarily malnutrition and further deterioration of a previously malnourished patient. So both these categories of patients who are well nourished can become malnourished. Malnourished patients can become more poorly nourished patients. So malnutrition is significant prognostic risk for a critically ill patient because they influence the outcome such as mortality, length of hospital stay, duration of mechanical ventilation, and infection rates. These are the 4 things that get affected because of inadequate or malnutrition. The second question is who? How do you assess the nutritional status to decide whether this patient requires nutritional support or not? The patients in whom multi-organ insufficiency or failure cannot be prevented or broken through medical nutrition. Patients who recover quickly, who do not require multinutritional therapy. Patients in whom disease course may be positively influenced by an individual. So you get 3 categories of patients. One patient is, he has gone to the extremist. He has already developed multi-organ failure. And by just supporting this nutrition, you are not going to achieve. You may have that kind of patients. The second category of patients, they come to the ICU with a temporary disablement, but they recover very fast. And even before you think of nutritional support, they are fit enough to be transferred out from the ICU to the second level or the ward and then get discharged. But this is the third category of patients where they are intermediately there in the ICU, where they are not able to take anything enterally. I mean, we are not able to extubate them and start them on regular oral feeds. And their possibility of recovery mainly depends on proper nutritional support. So this is the third category of patients who require nutritional support. So this classification, who depends on, we must classify the patients into these 3 categories. Extremely sick patient who may die anytime because of multi-organ failure. There is no point in thinking and wasting time about nutrition in them, because you are all the time trying to support the kidney by renal replacement therapy, you are supporting the respiration by mechanical ventilation, you are supporting the cardiovascular system with inotropes or even ECMO and other features. So in such patients, there is no point in thinking about nutrition. Second, patients who recover very fast, they also don't require, because they can start oral feedings as early as possible. But it is this intermediate category who require that. So it may be easy to identify the undernourished patient with low body weight and body mass index during routine clinical or normal evaluation of BMI to detect the malnutrition category. But there are no validated and recommended tools to estimate the nutritional status of a critically ill patient. This is the most challenging task in them. But some tools to estimate the risks are nutrition risk score, Nutric score, nutrition risk in the critically ill score, subjective global assessment, and malnutrition universal screening tools. These are some of the tools which are used. Then you take medical history, age, comorbidities, and loss of physical function. Nutrition history, whether the patient had any weight loss, reduced food intake, or loss of appetite. Then physical examination, what is the BMI of the patient, whether the patient is edematous, and how is the body composition. And severity of illness, critically ill patients are severely ill by definition. And weighing critically ill patients should be mandatory, but feasibility may be limited. In the Western countries, you have the ICU beds, which have an automatic weighing scale. So you can record the patient's weight every day or even twice or thrice a day, and you can adjust your diuretics, your fluid, your nutrition, everything can be done by that. So weighing is very important. Change of volume status, repeat weight measurements, and clinical examinations such as anthropometry. So if the patient becomes edematous one day and you give Lasix and he passes a lot of urine, then the weight will suddenly decrease. So volume status plays a very important impediment to weight measurement. The ESPN guideline defines every patient who is ICU for more than 48 hours to be at a risk of lack of nutrition. So regarding the technical tools, you can use computer tomography, scan analysis, musculoskeletal ultrasound, and bioelectrical impedance analysis may be available for assessment and monitoring the nutritional status in ICU, but are not broadly implemented into clinical routine. Then the third question is how to start the route of nutrition. There are two possibilities as described in detail. One is enteral nutrition. The physiological advantage are use the gut or lose it. That is the paradigm. And the adverse effects in the parenteral nutrition are where increase the cost of it. It's quite expensive. And parenteral nutrition is quite expensive, and whereas enteral nutrition, you can cost wise is much cheaper. And contraindications to enteral nutrition include the hemodynamic instability, escalation of high vasopressor medication. So before you think of enteral nutrition, you must make sure that the ICU patient is hemodynamically stable without requirement of much of inotropes or vasopressors, and whether the GI intolerance will be there, whether the gut is functioning or not. This is a very important thing. And of course, what are all the advantages she has already mentioned, so I don't want to repeat them. Then there is another thing called combined enteral nutrition with parenteral nutrition. This is another option that they give. So if you cannot feed them fully and all the elements that you require to feed with enteral nutrition, you can partly give parenteral nutrition also. And the EN is preferred in almost all ICU patients. Macronutrient targets may not be reached with EN alone in the acute phase. That is the reason why you have to go for this combination. The addition of parenteral nutrition or the use of parenteral nutrition may be considered on a case-to-case basis. Then the third thing is how much to give, energy and protein requirements. Prefer about indirect calorimetry method. This is the latest technology which is used to decide how much of nutritional support you should give. So this has become a topic by itself. Indirect calorimetry measurement is a short note question or a question that is asked in the theory papers in your exams nowadays. So weight adapted formulas may be used alternatively, and energy requirement is 24 to 30 kilocalories per kg per day, and protein requirement of that is 1 to 2 gram per kg per day. And do not neglect non-nutritional calories. Then the fifth question is when the timing of nutrition. Initiate enteral nutrition within 24 to 48 hours in patients without contraindications. Optimize enteral nutrition delivery. Addition of parenteral nutrition needs individual adaptation. Then what are the formula considerations? What are all the things that you can give? Standard formula should be chosen for most ICU patients. Consider energy dense formulas in patients with fluid restrictions and in malnourished patients. Intensified blood sugar monitor must be beneficial in patients with energy dense formula. I heard Vidya saying that you should not worry about blood sugar. I don't think that is the correct answer. You must monitor the blood sugar and keep a watch on that and use insulin as and when required to keep the blood sugar below 180 in these patients. That is very important. Otherwise, they will go for severe hyperglycemia, which will have its own adverse effects.
Okay.
So these are all the phases of the inflammatory status. M phase, flow phase. The flow phase is divided into catabolic and anabolic phase, and these are the various things which timing. The F phase happens within the first 24 hours. Then the flow phase, catabolic phase is 3 to 10 days, and anabolic phase is 10 to 60 days. And here mainly we concentrate on maintenance of blood volume and catecholamine support. Then physiologically there is a decrease in basal metabolic rate, decrease in temperature, decrease in oxygen consumption, vasoconstriction, increase in cardiac output, increase in heart rate, and increase in acute phase proteins. These are all the responses in the body in F phase. And the hormones secreted are all catecholamine, cortisol, and aldosterone. Once after 24 hours, the inflammatory process goes into the flow phase where the catabolic state starts, and it is by the breakdown of all your energy stores. That is the catabolism that is happening. Here the BMR increases, temperature increases, oxygen consumption increases, then there is a negative nitrogen balance. And here the insulin, glucagon, cortisol, catecholamine, and all these hormones are secreted, and patient also start developing insulin resistance at this stage. And the later phase is anabolic or rebuilding phase, replacement of lost tissue, positive nitrogen balance. Here the growth hormone and insulin-like growth factors are coming into play. Okay, so this is also another point which you have to. So based on this only, we have to decide how to give the nutritional support. Now, what are the supplementation with specific nutrition? The immune enhancing and anti-inflammatory nutrients is a challenging and controversial issue. So, arginine, glutamine, and omega-3 fatty acids are recommended. And selenium is also vitamin D, vitamin C, and there is a Maric cocktail, a treatment of intravenous hydrocortisone, ascorbic acid, and thiamine, which is in septic patients, found no significant difference in long term, but it has been tried as a supportive measure. And proven micronutrient deficiencies need to be treated, but not as a routine. And micronutrients must be supplemented whenever parenteral nutrition is administered. Now, what are the monitoring and complications that you have to expect? Clinical examination of the patient's abdomen. Blood chemistry includes serum glucose, triglycerides, lactate, and procalcitonin. Phosphate should be controlled to detect and treat potential refeeding syndrome. This is one of the important complications that can happen. Urea excretion per 24 hours will help to estimate the extent of catabolism. And for the estimation of intestinal function, biomarkers such as citrulline and fatty acid binding protein in the plasma can be done. Then gastrointestinal intolerance during enteral feeding. Many critically ill patients experience feeding intolerance, motility disorders, which may include delayed passage with slow gastric emptying and constipation, or accelerated passage with small intestinal absorption or nutrition related diarrhea. So it can be either constipation or diarrhea. The causes of GI intolerance are opioid analgesia, sedation, edema, and insufficient stimulation. So treatment options are oral enteral nutrition, prokinetics, mobilization, physical therapy, and optimization of the sedation and volume status. And clinical observation of patient's abdomen, I must do the abdominal girth measurement every day at umbilical level to find whether the patient is having a normal girth or any increase in the girth, indicating intestinal obstruction and bowel distension. So also auscultate the abdomen for the barbarrhythmia or bowel sounds, and gastric reflex also should be checked for. Then what are the metabolic intervals? Hyperglycemia may be due to hyperalimentation or a phase of insulin resistance underlying the subclinical diabetes. Hypertriglyceridemia is also because of the bolus lipids that you give. And reversible liver steatosis or hypertriglycemia induced acute pancreatitis is also another complication. And in severely malnourished patients, after long starving periods, they develop what is called refeeding syndrome, which may occur within the first few days of starting medical nutrition therapy. So supply of carbohydrates and fluid will stimulate insulin secretion and intracellular shift of glucose and electrolytes. The decrease in serum potassium, magnesium, and phosphate levels will lead to what is called impaired neuromuscular transmission, causing life-threatening arrhythmias and convulsions. So calories or fluid administration should be increased slowly under electrolyte and preferably ECG monitoring. In high-risk patients, a preventive thiamine administration of 200 milligram once daily for 2 days can take care of this particular problem. Now, this is the important thing, as I told you earlier. Hemodynamic stability is the important primary thing that you have to take care before thinking of nutrition. And the ICU nutrition protocol based on the practice guidelines. So once the patient is admitted, check if the patient is hemodynamically stable or not. So the first section is hemodynamic instability. The patient is 2 or more vasopressors or inotropes. Then if the patient is only hemodynamically stable, then you think of assessment for nutrition, calculate the nutrition requirement. If he is not hemodynamically stable, wait for the stabilization. Then once we think of nutrition, can you think of enteral nutrition in this patient? If it is, the answer is yes, then go for oral. Monitor patient's intake, whether he can swallow properly, and then start on oral or enteral nutrition according to if the requirements are not met. And whether you have to go for tube feeding, initiate enteral feeding by tube placement and start within 24 to 48 hours of admission. If the patient cannot be initiated on enteral nutrition, then you think of parenteral nutrition here if the patient is severely malnourished. Otherwise, start early, advance towards the full goal gradually, and then start with standard polymeric formula, trophic feeds of 10 to 20 ml per hour. Then check for tolerance. Patient tolerating feeds, start as tolerated, go to increase the calories as well as volume. So always start with a small volume, then gradually increase. In patients who are not tolerating even the small volume of 10 to 20 ml, evaluate the symptoms, patient conscious state, and check for the aspiration, residual volume. Then check the reasons for intolerance. Then measure to improve the tolerance. Then switch to semi-enteral formula. That is combination of enteral plus parenteral. So here they are giving all the guidelines. Section 2A, nutritional assessment, patient history, recent weight loss, history of alcoholism, drug abuse, assessment of present condition, and then energy protein requirement 25 to 30 calories. What I have told you earlier in this slide, you know that. And symptoms indicate gut dysfunction are regular regurgitation, nausea, vomiting, or aspiration. Gastric residual volume more than 300 ml, not 500 ml. Monitoring 4 to 8 hours. Diarrhea more than 3 stools. These are all indicative of bowel intolerance. And reasons for intolerance are antibiotics, or opioids or other asthmatic drugs and other medication. And then measure and improve prokinetics, head up tail, use of pyloric route feeding. That is, you can, instead of NG feeding, you go for NJ feeding. Avoid use of chlorhexidine mouthwash, and avoid ventilator assisted pneumonia by use of chlorhexidine and other things. And tailoring the nutrition to individual patient needs. This is the last slide. You can think of whether pre-existing malnutrition is there, then think of early nutrition, micronutrient supplementation. Be prepared to face this refeeding syndrome. And if the patient is obese, diagnosis of malnutrition, substrate utilization, deranged metabolism. The patient has a stroke, who may be in the critical unit, central nervous system, high risk for prolonged ICU stay. They may have dysphagia and aspiration if we try to start oral, and frequent GI dysmobility may be there. Patients who are sepsis and septic shock, they may early enteral feeding after they become hemodynamically stable, and metabolic and GI tolerance to be assessed, distribution of substrate utilization. And elderly patients, like that, everything you have, respiratory system, cardiovascular system patients, because critically ill means it encompasses all these various systems. So each one has to be given a nutrition tailored according to their condition. But the basic principles are every ICU patient is at the risk of malnutrition. Regular screening should be done to assess malnutrition. Close monitoring and frequent adaptations of nutrition have to be done. Always early enteral feeding is preferred. Micronutrients are mandatory if you are giving parenteral nutrition, and you must tailor the nutritional support to individual needs. So these are all the things that you have to remember. So instead of dwelling too much on enteral and parenteral nutrition, I think the answer for the question, if it is nutrition in ICU, this sort of presentation may be comprehensive and it will cover all the important points. Okay, so
Yes,
you
sir.
can